James, can you hear us in the conference room?
We can. We're still troubleshooting the mic, so we'll mute you.
I'll mute on our end so that we can unmute.
But we can't hear you for questions at the end. That'd be great. All right. On that note, I think we are just about to get started. I'm sure there will be a few more people that show up shortly, but I wanted to introduce today's virtual grand round speaker, Dr. Mary McDermott, who is joining us from Chicago, cold Chicago apparently, and as it usually is, and from the Northwestern University, Feinberg School of Medicine. She'll be talking to us today about peripheral arterial disease. So by way of further introduction, Dr. Mary McDermott is a Jeremiah Stamler Professor of Medicine in the Division of General Internal Medicine and Geriatrics and of Preventive Medicine at Northwestern University's Feinberg School of Medicine. Dr. McDermott has devoted her career to advancing our understanding of peripheral arterial disease, including documenting the magnitude and significance of declines in walking ability over time in patients with peripheral arterial disease, and identifying treatments to improve walking performance in peripheral arterial disease. As the principal investigator of numerous randomized clinical trials on PAD funded by grants from the National Institute on Aging and the National Heart, Lung, and Blood Institute, divisions of the NIH, Dr. McDermott's research team currently focuses on interventions to reduce or prevent mobility loss and enhance the quality of life for individuals with PAD. As many of you know, she is also a deputy editor at the Journal of American Medical Association. So we are truly fortunate to have you, Dr. McDermott, and all your expertise on peripheral arterial disease. I'll let you take it away.
Well, thank you so much, James. And it's a pleasure to be here and to see some friends on the Zoom as well. So as James indicated, I'm going to be talking today about peripheral artery disease. Here's an outline of what I plan to talk about. I'm going to talk a little bit about diagnosis and also management of peripheral artery disease, both with regard to preventing cardiovascular events and improving walking impairment. And then James asked me to talk about disparities in PAD. And I was telling James before we got started that there's good evidence of multiple types of disparities in diagnosis and treatment of PAD, but not so much evidence about how do we overcome those. But I will intersperse that through my talk. So I wanted to talk first about diagnosis of peripheral artery disease and the fact that we classically think of intermittent claudication as the typical symptom of PAD, kind of like classic angina for coronary artery disease. Claudication is characterized by exertional calf pain that begins with walking, not at rest, and that resolves within 10 minutes of rest. It turns out that these symptoms are extremely insensitive to detect peripheral artery disease. And if we relied only on symptoms to detect PAD, we would miss most PAD. I don't know how many people with coronary artery disease don't have classic angina, but I can tell you that in epidemiologic studies, it's fewer than 10% of people with PAD who have classic intermittent claudication symptoms. And these are data here from the Cardiovascular Health Study of about 5,000 people 65 and older, showing the prevalence of PAD of 12%, but that only 1% had classic claudication. And even in a vascular lab, this bar here is showing the WALKS cohort, which was patients recruited in Chicago with peripheral artery disease, 460 of them, only 1/3 had classic symptoms. And I think the absence of classic PAD or classic claudication symptoms in many PAD patients most certainly contributes to a problem of underdiagnosis. And PAD has been notoriously underdiagnosed and undertreated. So I'm sure that you are familiar with the ankle brachial index, which is a much more sensitive way to identify peripheral artery disease. As a reminder, the ankle brachial index is such a beautiful test, partly because it's non-invasive and it doesn't require expensive equipment, but also it relies on the principle that arterial pressures normally increase with increasing distance from the heart. So in an individual with no atherosclerotic blockages in their arteries, the pressures at the ankle should be higher than the pressures at the brachial artery. And so a truly normal ankle brachial index is between about 1.1 and 1.3 or maybe 1.4. But we traditionally use an ankle brachial index of less than 0.9 to diagnose PAD. But you should know that an ABI between 0.91 and 1.09 is not normal. And as I'm going to show you today, people with an ABI in that range, even though they may not carry a diagnosis of PAD, they still have poor difficulty walking and they have higher rates of cardiovascular events than people with an ABI within that normal range of 1.1 to about 1.3 or 1.4. But even an ABI less than 0.9 is only about 72% sensitive for PAD, which means we can't really rely completely on a low ABI either. Often it's because of stiff peripheral vessels resulting in an artificially increased ABI in someone who has atherosclerotic disease. If one uses the ankle brachial index to look for PAD, it is extremely common. As I mentioned, it's often underdiagnosed, but multiple epidemiologic studies from the United States have documented a prevalence of 10 to 15% of people aged 65 and older. And if you look for PAD in patients in, say, general medicine practice, which the Partners study did, they found a 29% prevalence among people who were either age 70 and older or between the ages of 50 and 69 who had a history of smoking or diabetes, which are the two most powerful risk factors in addition to older age. And it has been estimated that 1 in 16 Americans age 40 and older has PAD. So with regard to disparities, there is a large disparity with regard to the prevalence of PAD. This slide shows the prevalence of PAD in men according to race ethnicity. And you can see that people who are Black, shown by this top line here, have about twofold the prevalence of PAD compared to people who are white or Hispanic or American Indian. And this phenomenon is also observed in women. Here, we don't have a lot of data on American Indian populations, but at least the data that we do have suggests that the prevalence is also higher in that population. There is most certainly a higher prevalence of PAD in people who are Black and among women, among those who are American Indian. There's also disparities in prevalence by education and by socioeconomic status. These are data from N. Haynes. They were published, or they were collected between 1994 and 2004, so a little bit old, but they demonstrate that lower income, which is shown with the poverty income ratio on the x-axis, and a ratio less than 1 means that income is less than the poverty line. And these numbers represent the income relative to the poverty line. And you can see that even people who had whose income was twice the poverty level had substantially higher prevalence of PAD compared to people with higher incomes. So there's also that disparity. Cardiovascular outcomes in people with peripheral artery disease are increased. That's one of the main clinical significance of PAD is the high rate of cardiovascular event. One thing that's always interested me is that cardiovascular disease in different arterial beds is not identical. So, these are data from the REACH registry, which was tens of thousands of people from about 44 different countries. And what they found is that about 61% of people with PAD also had coronary disease or cerebral vascular disease. But you can see that most people with CAD did not have PAD. So, why do some people develop peripheral artery disease but not develop coronary disease? We don't have the answer to that, but there do seem to be differences in the nature of atherosclerosis, with lower extremity atherosclerosis comprised more of thrombosis oftentimes than, say, lipid-rich plaque, for example. We also know that risk factors are not identical for cardiovascular disease in different arteries, so that diabetes is actually a stronger risk factor for PAD than it is for coronary disease. And smoking is also a stronger risk factor for peripheral artery disease than it is for coronary artery disease. And the reasons for that are not clear. Obviously, the caliber of the vessels differs between the lower extremity arteries being much larger compared to the coronaries, but they're truly not interchangeable. But patients with PAD, as I'll show you today, seem to have particularly high rates of cardiovascular events. This slide combines data from epidemiologic studies, and it shows the relationship between PAD, and this is all-cause mortality, but you could construct a very similar graph for the outcome of cardiovascular mortality or cardiovascular events. And the circles are women and the triangles are men, the x-axis, the ankle brachial index, and the y-axis, the hazard ratio for all-cause mortality in this case. And earlier I was talking about how a truly normal ABI is within this range. You can see this is the reference with regard to total mortality, and even people who have slightly low ABI values below those range, but perhaps not yet considered PAD, have higher rates of all-cause mortality than people within that normal range. And the more severe the PAD indicated by lower ABI values, the higher rate of all-cause mortality and also cardiovascular events. And so one of our main treatment goals for patients with PAD is to prevent cardiovascular events and prolong life with secondary prevention. And there are a whole lot of therapies for doing that, addressing smoking cessation, hypertension, antiplatelet therapy, cholesterol, and more. And I don't really have time to go into depth on all of these. And I thought what I would do today is highlight some things that are perhaps more unique to peripheral artery disease. And in particular, the antiplatelet therapy story for peripheral artery disease, I would say, is different than for coronary artery disease, and certainly interesting and a bit complex. So with regard to antiplatelet therapy for peripheral artery disease, the current AHA clinical practice guidelines, which are from 2016, so maybe a bit dated, but they recommend, with regard to antiplatelet therapy, either low-dose aspirin or clopidogrel 75 milligrams to prevent cardiovascular events in patients with symptomatic PAD. And that recommendation largely comes from the Antithrombotic Trialist Collaboration and their meta-analysis of nearly 10,000 PAD patients from 42 randomized clinical trials, which demonstrated that antiplatelet therapy compared to placebo overall, on average, reduced rates of cardiovascular events by about 22%. But what isn't clear from this, but is more recently clear, is that most of those studies demonstrating that benefit of 22% reduction aren't aspirin studies. And if you look specifically at aspirin for PAD, it doesn't do as well. And this meta-analysis published in JAMA combined data from randomized clinical trials that compared aspirin specifically to placebo for preventing cardiovascular events. And the finding was that there was a point estimate of 0.88 suggesting benefit, but with the sample size of about 6,000 people, not statistically significant, indicating certainly not as strong a benefit as was suggested by the antithrombotic trialist collaboration. And I would say that evidence suggests that P2Y12 receptor inhibitors are probably more effective for patients with PAD than aspirin. And that signal for the benefits of P2Y12 inhibitors first came really from the Capri trial, which, as you'll recall, was a randomized clinical trial that compared clopidogrel to aspirin in 19,000 patients who had either stroke, MI, or peripheral artery disease, with about a third of patients with each of those conditions. And it demonstrated a slight benefit favoring clopidogrel that was statistically significant. But in post hoc analyses, when the results were broken out by type of cardiovascular disease that got people in the trial, it was clear that the patients with peripheral artery disease seemed to preferentially benefit from the clopidogrel as compared to aspirin. And later, in post hoc analyses from the Pegasus TIMI 52 trial, which randomized patients with a recent myocardial infarction in the last 3 years to aspirin plus either the ticagrelor or placebo, and demonstrated benefit for ticagrelor in post hoc analyses when the results were broken out by PAD patients. There's two things that this slide really illustrates well. One is that you can see that the participants in this trial who had PAD, whether they were in the ticagrelor or the placebo group, had higher rates of cardiovascular events than those without PAD. But you can also see that they benefited significantly from the ticagrelor with the number needed to treat of 25 compared to a number needed to treat of 100 for those without peripheral artery disease. Subsequently, the Euclid trial was published, which compared ticagrelor to clopidogrel for the outcome of cardiovascular events in over 13,000 patients with peripheral artery disease. This is one of few clinical trials that included only patients with peripheral artery disease. And when I mentioned at the outset that PAD has traditionally been underdiagnosed and undertreated, I think you could take that farther and say that PAD has been underappreciated, overlooked. And of course, you could consider me biased. I would not disagree with that. But there are so many more clinical trials that have focused on coronary disease and very few that have focused specifically on peripheral artery disease. But this was one of them, the Euclid trial. And the investigators expected to see that ticagrelor would be better than clopidogrel for preventing cardiovascular events, but actually it showed that they were not different from each other. I wanted to mention Vorapaxar, which is another novel antiplatelet agent that acts to prevent thrombin activation of platelets through the protease activated receptor 1. And it not only prevents activation of platelets, but it has a mechanism that prevents smooth muscle mitogenesis. And this is more important, perhaps, for lower extremity atherosclerosis. And so I think the results were of particular interest in peripheral artery disease. But the overall trial demonstrated benefits of Vorapaxar compared to placebo for preventing cardiovascular events in a population of patients with either PAD or MI or stroke. When one looked at the PAD subset of participants, there was no significant difference in response. That is, there was no interaction to suggest that PAD patients responded differently. But when you looked at the outcome of major adverse limb event, and this is an increasingly evaluated outcome, which consists typically of amputation, acute limb ischemia, or the urgent need for revascularization. And here you can see a point estimate that was smaller than the point estimate for overall prevention of cardiovascular events, with this point estimate for preventing major adverse limb events of 0.58, favoring the Vorapaxar. And again, multiple trials now have shown that, well, antiplatelet agents such as the P2Y12 or Varipaxar or PCSK9 inhibitors specifically prevent major adverse limb events. And this is increasingly recognized as an important outcome because of its incidence, particularly in patients with PAD. But Varipaxar, the clinical practice guidelines, do not recommend it. They say the role is uncertain, and that has to do with the fact that it was associated with moderate to severe bleeding. The COMPASS trial is another very important study of, in this case, antithrombotic combined with antiplatelet therapy. The COMPASS trial consisted of 7,470 patients with PAD or carotid atherosclerosis who are randomized to either low-dose aspirin, rivaroxaban 5 milligrams BID, or rivaroxaban 2.5 milligrams BID plus aspirin. The primary outcome was cardiovascular events, and they also looked at major adverse limb events. There were two primary hypotheses. One was that rivaroxaban 5 milligrams BID would be better than aspirin. The second, that rivaroxaban low dose plus aspirin would be better than 100 milligrams of aspirin, but only the latter showed statistical significance. These are results for cardiovascular events. And you can see the green line, the rates of cardiovascular events in those who had low dose rivaroxaban plus aspirin versus aspirin alone, with a point estimate of 0.72. And the rivaroxaban alone was not better than aspirin. And there was also significant benefit, again, for the low-dose rivaroxaban with low-dose aspirin in preventing those major adverse limb events. And also the benefits of low-dose rivaroxaban with low-dose aspirin were also demonstrated in the Voyager trial, which studied this combination of therapy compared to aspirin alone in patients after lower extremity revascularization. This was the Voyager trial, another one of the relatively small number of large randomized clinical trials of cardiovascular events limited to patients with PAD. So just to sum up, the antiplatelet therapy in PAD story is somewhat complex, but the evidence does suggest that the P2Y12 inhibitors are better than aspirin for preventing both cardiovascular events and major adverse limb events. Ticagrelor and clopidogrel have similar efficacy in the Euclid trial. Now, more recently, the rivaroxaban low dose plus low dose aspirin is also a viable therapy, a good therapy for preventing cardiovascular events. And no one, to my knowledge, has compared that to, say, the P2Y12 inhibitors. And the role of Varipaxar is uncertain at this time, again, primarily because of the higher rate of moderate and severe bleeding. I want to talk briefly about lipid lowering for management of peripheral artery disease. The current guidelines say that all PAD patients should be treated with maximally tolerated doses of potent statins to attain an LDL less than 70, and ezetimibe and PCSK9 inhibitors should be added as needed to attain an LDL less than 70. The European guidelines recommend even more intensive lipid lowering therapy. They recommend lowering LDL to less than 55 and also a 50% reduction minimum in the LDL. And these are data from the heart protection study, which had a good number of PAD patients and showed in this trial of simvastatin versus placebo that PAD patients benefited similarly to the other subgroups of patients in this trial, with about a 24% reduction in cardiovascular event rates. But PCSK9 inhibitors also have a role. As I mentioned, the AHA guidelines suggest that it should be used if ezetimibe and high-dose statins are not sufficient to get the LDL less than 70. The Fourier trial did a post hoc analysis of patients with PAD. All the participants were already on a statin therapy, but their LDL was above 70. and showed a significant benefit in further reducing cardiovascular events in PAD patients for those treated with evolocumab compared to placebo. And again, you see this higher rate of cardiovascular events in the PAD patient shown by the top two solid lines compared to those without PAD shown with the dotted lines there, with the number needed to treat being just 29 for the PAD compared to 63 for the entire, or for the people that did not have PAD. And also in this trial, evolocumab also significantly reduced rates of the major adverse limb events compared to placebo. So tight LDL lowering is beneficial. With regard to antihypertensive therapy, the guidelines have recommended lowering blood pressure to less than 130/80. And they recommend angiotensin enzyme inhibitors or angiotensin receptor blockers preferentially. We don't really have great data for this. We don't really have, I'm not aware of any PAD only trials that can tell us really what the best antihypertensive therapy is for PAD patients. But in the HOPE trial, there were a lot of PAD participants in that trial, and they benefited at least as much from ramipril as those without peripheral artery disease. And one can't talk about cardiovascular disease prevention without mentioning smoking cessation. Smoking, as I mentioned, is one of the strongest risk factors for PAD, and even people who quit smoking, 20 years ago actually remain at lifelong higher risk of developing PAD than those who never smoked. The reason for that is currently unclear, but it's true that people who continue to smoke with PAD are at much higher rate of developing gangrene or severe PAD. So all patients, including those with PAD, should be helped to quit smoking with pharmacotherapy and referral to a smoking cessation program. And SGLT2 inhibitors and GLP-1 receptor agonists are also likely to be important for reducing outcomes in PAD. There is some evidence that liraglutide in a small number of events, but reduced rates of amputation in one study. And SGLT2 inhibitors, these are data from showing that empagliflozin significantly reduced rates of cardiovascular events in the subset of patients with PAD and diabetes, suggesting a role, demonstrating that the SGLT2 inhibitors are also effective. There was a concern about canagliflozin and rates of amputation. For a while, there was a black box warning based on some early clinical trial evidence. That has now been reduced to just a precaution and has not been observed with other SGLT2 inhibitors. So I would not avoid these drugs in patients with PAD. So I want to turn next to talking about walking impairment in PAD, which is a special interest of mine. And when I first got started studying peripheral artery disease, this figure here was commonly seen in guidelines and also in textbooks of cardiovascular disease. And focusing your attention on the left-hand side of the slide on limb morbidity, this slide suggests that the natural history of PAD when it comes to walking performance is benign. And the reason for that is there were some studies done in the late 20th century that demonstrated that if you ask people with PAD over a 5-year period how their ischemic limb symptoms are, more than half of them will tell you that their symptoms are unchanged, and some of them will even tell you that their symptoms are improved, they're better. Only about 10 to 20% will say that their symptoms have gotten worse, and only a small percent will require an amputation or develop gangrene. But it turns out that this is really not a good paradigm for, it's not an accurate assessment of PAD walking performance at all. And in fact, what we've been able to show with some of our work where we have people come in for research visits and do 6-minute walk tests, that their symptoms may feel better to them, but it's because they have limited their physical activity. And when they do a 6-minute walk test, for example, it's quite common for someone to say that they don't have any leg symptoms anymore to develop leg symptoms. One of the first studies that we did here in Chicago to document the presence of significant mobility impairment in peripheral artery disease was our WALKS cohort, where we recruited 740 people from the Chicago area, including 460 with peripheral artery disease, and had the participants complete a 6-minute walk at baseline and then yearly for up to 4 years. And these are data from baseline showing just the really marked, almost exponential association between lower ABI values shown on the x-axis and the inability to walk for 6 minutes without stopping shown on the y-axis. This is the percent of people who couldn't complete a 6-minute walk without having to stop because of ischemic leg symptoms. And despite the fact that the PAD patients started with significant impairments, they also declined at a significantly faster rate in their 6-minute walk than those without PAD. So here you're seeing the y-axis, average annual decline. This is actually shown in feet here of 6-minute walk distance per year. Here are the people on the right-hand side of the graph without PAD declining at a rate of maybe 20 feet, per year, while those with mild to moderate or severe PAD are declining at significantly faster rates. So when we first enrolled patients, they were doing poorer in their 6-minute walk, and they also declined in their 6-minute walk at a significantly faster rate, despite the fact that many of them did tell us that their symptoms were stable or even improving as they perceived them. There is also disparity in rates of walking performance by race. In Chicago, we we're able to recruit a fair number of people who are Black from the Chicago area, and we observed that when we followed them over time, that people who were Black had significantly faster rates of mobility loss compared to those who were white. And also that they were more likely to become unable to walk 6 minutes without stopping during the 4-year follow-up that we had. Now, what we found also, importantly, is that when we adjusted for income according to their zip code, and when we adjusted for education level, these differences that you're seeing in the Kaplan-Meier curves were no longer present, consistent with race as a social construct and important in interpreting these results. So despite their significant walking impairment, we still have very few effective medical therapies for PAD. In 2024, there are only 2 FDA-approved drugs, cilostazol and pentoxifylline. There have not been any new FDA-approved drugs since cilostazol was approved in 1999. And cilostazol improves treadmill walking performance by about 30 to 40 meters, while walking exercise improves it by about 180 meters. So it's not very effective. Pentoxifylline in recent trials is not much better than placebo and is no longer recommended by clinical practice guidelines for PAD, as you see here. Supervised treadmill exercise has been considered the most effective medical therapy for patients with PAD. It is first-line therapy in the AHA guidelines from 2016. Home-based exercise therapy as of 2016 had a class 2A, meaning that it's recommended, but not first-line therapy with level of evidence A. I understand that some new PAD guidelines should be coming out hopefully this year. I really hope that this now becomes a class 1, because I do think that the evidence is there. So we have multiple randomized clinical trials of supervised exercise for PAD. These trials typically had patients walk for exercise on a treadmill for at least 12 weeks. And this is a meta-analysis of over 1,000 patients, over, 25 randomized trials. The benefit was 180-meter improvement from those who walked for exercise. That's 180 meters on the treadmill compared to a no walking exercise. I will say that the supervised exercise therapy that's done on a treadmill does particularly help patients become able to walk better on a treadmill. And I think part of the benefit that we've seen is perhaps helping people walk better on a treadmill, but also helping them improve their walking endurance. We've conducted several supervised exercise trials that have shown benefit in walking performance, including the 6-minute walk in PAD patients. We do not see differences by age, sex, race, ABI, body mass index, or any clinical characteristics. I have heard people say that people who are Black don't benefit from exercise. That is not correct, at least not in our trials. And we've been able to enroll about 50% people who are Black, and they respond very well to exercise, just as most people with PAD do. Based on this strong evidence from supervised exercise in 2017, Medicare made the decision to cover supervised exercise for PAD. They cover 12 weeks of exercise. It does not have to be on a treadmill, but it does have to take place at a hospital or outpatient hospital setting similar to cardiac rehab. It must take place under the direction of a physician, and the referral must come from an in-person visit with a physician where risk factor modification is also discussed. That was, for those of us that think all day about PAD, we thought this would be a game changer, but it has not been a game changer. We thought it'd be a game changer because so few people with PAD typically participate in supervised exercise. We thought that the Medicare coverage would change that, but it hasn't. These are data from Eric Sosempsky's analysis of Medicare data the first 18 months after Medicare approved supervised exercise for coverage. The red line is showing that 98.7% of people with a diagnosis of PAD and Medicare database did not participate in the first 18 months after Medicare began to cover it. And only 89 people out of 129,000 actually completed all 36 sessions covered by Medicare. I think there's a lot of reasons for lack of participation. I think, some of it is it's hard to travel to an exercise center 3 days a week to participate in exercise, but there's also a problem with availability of the programs. This slide is summarizing data from a physician survey of cardiologists and vascular surgeons and vascular medicine specialists. It was not a large survey study, but it included people from all 50 states, and over half either hadn't referred a patient for cardiac rehab after it was covered by Medicare or didn't know that it was available. So it's a real problem. The Medicare reimbursement is not a lot. I know I'm a little embarrassed to tell you that our hospital does not cover it. And it's really hard to find programs in the Chicago area. I would also point out that supervised exercise, despite its benefit, it doesn't immediately improve walking performance, and that can be frustrating for patients. So when they are able to participate, I think it's really important to educate them that the improvement is rather slow, but they should notice benefit after about 4 to 6 weeks. And also, though, gains are rapidly lost when the program goes away. And so it's really important to help them find a place that they can continue their exercise. Home-based exercise would overcome many of the obstacles to supervised exercise, such as having a facility to go to or the burden of having to go to a facility. But for many years, the clinical practice guidelines said there was no evidence to support walking for exercise at home. I think that has now changed, and some of our work has contributed to the body of evidence to demonstrate that home-based exercise can be effective. But it's still also true that you can't just tell patients to go home and walk. The programs that have been effective have had regular weekly follow-up or similar type frequency of follow-up with the PAD patient, a coach to be accountable to, even if it's just by telephone, and incorporate the general principles we know to be important for behavioral change interventions, such as building self-efficacy and having the patient self-monitor and being accountable to a coach. One of the first trials that demonstrated benefit of home-based exercise was our GOALS clinical trial, where we had 192 patients with PAD randomized to either a home-based exercise intervention or a control group that got information but not a coach or a group to work with. In this intervention, patients actually came to the medical center weekly to meet in a group with other PAD patients and a coach. And we helped them establish, we wanted them to establish a habit of walking for exercise. So we asked them to walk 5 days a week if they were able. And we helped them learn to self-monitor, write down what they were going to do and record what they did. They got support from the coach and from others in their with PAD in their group. And it was a really potent intervention. It improved the 6-minute walk by about 53 meters compared to the control group, which is quite a large benefit. It also improved patient-reported outcomes. It improved just about all the outcomes that we evaluated. And so not only were we able to demonstrate that walking for exercise at home can work if you give the patients enough support, but we also demonstrated that 6 months after we took away the intervention, because the trial ended, that there was still a signal of benefit, not quite as strong, but there was still greater improvement compared to the control group. I also want to talk about our light randomized clinical trial of home-based exercise in PAD. We designed this trial because walking for exercise in PAD patients has an added layer of difficulty because of the ischemic leg symptoms that they can't avoid when they go to walk. Patients with PAD go to walk for exercise. And we thought that maybe if we asked patients to walk for exercise at a pace that was comfortable and didn't induce those ischemic symptoms, that they would walk more, and that might yield greater benefit than the traditional asking them to walk to ischemic leg symptoms. So we designed a multi-centered randomized clinical trial where patients with PAD were randomized to either the low intensity exercise, where they were asked to walk at home at a comfortable pace without ischemic leg symptoms, or to traditional high intensity, where we said, please, you should be walking to get ischemic leg symptoms within 10 minutes of beginning your walking. And if you're not doing that, then we'd like you to pick up the pace, or a control group that did not get any exercise, got information. And the two exercise interventions were identical. We asked people to walk 5 days a week. We asked them to work up to 50 minutes per session if they could. We gave everybody weekly telephone coaching calls with the same coach, and we gave them an actigraph to monitor their intensity. And we did that by having them wear the actigraph and walk at a high intensity pace, and then recording what the actigraph said about intensity, and then at a very comfortable pace and recording what the actigraph said about intensity. And so we were able to actually, they wore the device during exercise and uploaded it to the website, and we were able to monitor the intensity of their exercise, and they were too. So we were together kind of monitoring how they were doing. So we randomized 300 people, which was our target sample. We had about 50% women. We had 59% people who were Black. And we did attain this big difference in intensity, because what you're seeing up here is combined data for everybody randomized to high intensity. You can see that on the actigraph, they did achieve quite a higher intensity of walking exercise than those in low intensity. We were correct that low intensity would yield more walking exercise, and those randomized to low intensity actually walked about twice as many minutes per week as those randomized to high intensity. So clearly indicating that the walking exercise was much more difficult for those randomized to the exercise-inducing ischemic symptoms. And you can see that only 65% of the time did people get within that desired range of intensity measured by the actigraph. But despite all of that, we found that the low intensity exercise did not do better than the control group, even though they were walking all those exercise minutes, while the high intensity group did significantly improve their 6-minute walk distance, getting a gain that was about 49 meters, which was quite similar to what we saw in goals. We also found a similar benefit for treadmill walking in the high intensity compared to control, and we did not see the same benefit in the low intensity. The only things where we saw benefit in the low intensity, and this was really interesting, is they felt that their walking had improved. And when we had them fill out the patient-reported outcome measures, they did as well as the high intensity group. But when it came to the objective assessment, their 6-minute walk did not significantly improve. So this was really eye-opening for me. It demonstrated that inducing the ischemic symptoms was necessary to get at least objective improvement in walking performance. And consequently, we're, in our ongoing trials of exercise, we are encouraging people to walk at this high-intensity pace. And we're also doing some investigation to try to figure out what it is about the ischemia being induced that is necessary to gain benefit. So the last few minutes, I'm gonna talk a little bit more about disparities in PAD, and disparities have been demonstrated in PAD by sex, race, geography, and socioeconomic status. And I've already shown you some data on race and socioeconomic status. There are disparities by sex, but I think sex is a little bit different because, for example, we've shown that women have poorer 6-minute walk than men. But that's also true in people without PAD. It's not unique to PAD. And there is evidence showing that women have smaller arteries than men. I think the area that is in particularly need of study with regard to sex and PAD is studies of interventions, because there are a lot of interventions being performed to open arteries in people with PAD to improve their walking. And these trials do mainly consist of men, and the devices, it may be true that different stents are needed for women than men because of differences in their arteries. And we don't have data today on that. Race, it is well documented that there's higher prevalence and poorer outcomes, particularly with regard to amputations in people who are Black. And this is a real problem that needs to be addressed. And I'm going to talk in a moment about different potential causes. And then geography, there are large differences in rates of procedures. I'm going to show you in a minute. Rates of amputation differ largely by geography across the United States, and also some differences by socioeconomic status. This map you can Google. The website is at the bottom of the slide. It was developed by the PAD Collaborative, which was initiated by the AHA, but includes many organizations across the world, really, that are designed to help improve awareness and treatment of PAD, and also with a goal of eliminating disparities. This map was recently published, and it shows where amputations were performed in the United States in 2017 and 2018, with red being the highest rates, particularly high in Mississippi, but also Louisiana and other southern states in particular. Chicago is, up here, and San Francisco, where it is better than I do on this map, but, maybe not so bad. But why the difference in amputation rates across the United States is unclear, but there's a real concern about access to care and the ability to identify PAD early enough and treat it to avoid amputation. Here are some data on rates of revascularization prior to amputation, showing that people who are Black are less likely to be revascularized prior to amputation. These are data from Medicare across the United States. And the reason for this this disparity is unclear, but it's not the case that people are, it can't be explained just by, well, people who are Black are presenting at the too late, because you can see that even when the investigators looked at the proportion of people with amputation who had 3 or more revascularizations, there were still discrepancies. So it's not, it's likely there are multiple reasons for this, but certainly it's not just a late presentation that can explain this, I think. So when approaching disparities in PAD, again, disparities have been identified in all 4 of these parameters. And I think there's likely multiple reasons for these disparities, including unequal access to optimal care, racism, poor knowledge and an awareness of PAD. And I think educating people about the disparities is really important as well. Sexism may contribute to some disparities, and certainly wealth inequality as well. And I do think I mentioned at the outset that PAD is under-recognized, it's underdiagnosed, it's undertreated. I do think that these disparities are contributing to this problem of underdiagnosis and undertreatment. And if we can eliminate these disparities, that will move us a step forward toward better diagnosis and better treatment of all patients with PAD. So this is my last slide. And I hope I've helped inform you about management of patients with regard to preventing cardiovascular events and the importance of diagnosis and intensive treatment and therapies to improve walking performance in PAD patients. And really, I think to eliminate the disparities, we definitely need more science that not to just document, but also develop interventions that can eliminate disparities and improve health for all patients with PAD. So I'd be happy to take your questions.